right, I think with that, we'll go ahead and get started. Looks like our waiting room is slowed down a little bit. Well, thank you all for being here today. We are here for clinical access, doesn't mean research access. We're going to talk about everybody's favorite thing, HIPAA. So thank you for being here with us and how it applies to clinical research. As always, I have a couple housekeeping items like I do. One, if you're on the Zoom, if you could please place your name and your email in the chat for attendance purposes, I would greatly appreciate it. I have already cleared that the presenters today, and we have 3 of them, are going to share their slides with us. So I will send out the sign-in sheet and the slides afterwards. To go ahead and if you would like to either keep those in your files, or I know some of you like to have access to give them to ACRP or SOCRA for potential credit, that would be great as well. My other housekeeping item, let me let these people in. The other housekeeping item is this presentation. We do have someone on here from our West Virginia University IRB. The other 2 presenters are also here at West Virginia University. So they may give some information that might be more specific to WVU. So if you are with our charter site members, please make sure that if you have a question, you may need to take it back to your institution just to make sure that they're in that same agreement because this is WVU University. The other thing is we are going to take questions in the moment. For Cassandra that's on Zoom with us, she's one of our presenters. Myself and Emily will watch the chat for you, Cassandra, so you don't have to take care of all of that. So, all right, I think those are my admin things. I will drop the CE form in at the very end of the presentation today. So if you would like CEs, and for those in the room, I'll definitely get that form too if you want that. So I'll drop that in, and then it's your responsibility to return that to me. I'm Debbie Lee, and you would have received the invite from me or Kylie, so you can just send that back to me. All right, with that, I'd like to introduce our presenters. So our first, the person that will be presenting first is Michelle Chittister. She's here to my right, and she is the Assistant Director for Regulatory and Quality at WVCTSI Center of Excellence. She has over 20 years experience, I should have said 2 decades, in research and has been at WVCTSI for 8 years. Our next presenter will be Wes Kimball. He's the Director of Research Data and Analytics for the I'm just going to say for WVCTSI because that's a mouthful. He's responsible for providing operational oversight and guidance in the management and execution of clinical informatics research and new data informatics infrastructure for West Virginia University's Academic Medical Center. Wes's research expertise involves the use of clinical data from healthcare electronic medical records, including utilization of clinical imaging in large data warehouses, as well as being a study member of many NIH projects. He has extensive knowledge in the use of protected health information and the Health Insurance Portability Accountability Act for research purposes. He is currently a WVU IRB member and is on multiple data governance committees. And then our third presenter is Cassandra Lambert, and she's currently the Assistant Director for the Office of Human Research Protections at WVU. She began her IRB career at the University of Colorado, where she served as an IRB review specialist before transitioning to the University of Kentucky to focus on quality improvement, education, and outreach. So with that, I'm going to go ahead and pass it over to Michelle. If you do have questions that you place in the chat, if you could send them to either Debbie, that's not projecting in the room, or to Emily Kemper, we'll make sure we get those answered for you. Okay. With that, I'll pass it to Michelle Chittister.
So what is HIPAA? We hear this term all the time when you go to the doctor's office, and most of us probably work in healthcare. So when you're seeing patients, if you're putting documents in for an IRB review, if you're reading a protocol, It is an acronym that stands for the Health Insurance Portability Accountability Act. It is a federal statute which sets standards for storing, managing, transmitting, and sharing of protected health information. Debbie, we have an issue.
What's your issue?
Just one moment, please. We're not moving over on this one. We're having a little technical issue. There we go. It is a federal statute which stands which sets standards for storing, managing, transmitting, and sharing of protected health information, or PHI. It applies to any workers who are employed under the covered entity that has access or uses patient healthcare data, as well as any business associates of the entity, such as insurance providers. It requires covered entities to maintain reasonable and appropriate administrative, technical, and physical safeguards for protecting health information. And that can be, for instance, a secure computer system with a password, things like that. PHI is any information in the medical record or designated record set that can be used to identify an individual and that was created, used, or disclosed in the course of providing healthcare service, and that is your protected health information.
With that, I think we're going to pass it over to Cassandra. Or to Wes, I'm sorry.
Oh, to Wes. Wes is up. Awesome. Thank you, guys. So protected healthcare identifiers under HIPAA. So something that a lot of folks that do research, I actually encounter this quite often. They don't realize exactly what qualifies as an element of PHI. So a protected healthcare identifier. So on this slide is just a list of anything, any one of these is considered an element of PHI. There are some additional regulations that allow, certain things to be shared. If they're only shared in, you can share age, you can share specific elements of age, you can share geographical information if you're going to share institutionally. That's something that would be considered a limited data set under the federal regulations. So it's not anything that's a full-blown identifier like your name, your social security number, your MRN, which is your medical record number. But those are things that we have to consider that are elements of protected healthcare information. So you can see that the list here, I think there's, and please don't count and tell me I'm wrong, but I believe there's 18 unless they've added something. But you can see all the way down there the things that people may not even think about when they're working with data or they're working with anything from the medical record. So you can see things like account numbers, a unique identifying number, characteristic, or code. So what could that actually be? That's kind of vague. If you look at an X-ray and somebody has a knee implant, that implant has a serial number on it that is tied directly to that person. That is an element of PHI. So although you look down through this list and you oftentimes we think, oh yeah, well, I'm not using names, I'm not using telephone number, vehicle identifier like a VIN, license plate, any of that kind of thing, doesn't necessarily mean you're not working with PHI, because some of these again are sort of vague, but you have to think through it to determine if it is PHI or not. And if you don't know, certainly most institutions should have somebody that you could ask and get their opinion on. So that's part of the gray area. And it also doesn't mean because it's not on the list that it's not PHI. And that's another kind of complicated thing. So we may not use, and I'm just going to using clinical data as an example, because that's sort of what I work in, that area. But if you're doing clinical trials, if you're, and what Cassandra will talk about shortly, if you're using a HIPAA waiver to identify potential patients, or you're going to pull some elements out of medical records into a protected, spreadsheet, a protected software. You may not pull any one of those 18 identifiers. Those 18 identifiers are what are listed under the safe harbor method of identification. So in order to comply with that regulation, none of those 18 identifiers can be present in your data set. Again, we may not use any one of those identifiers. However, think of elements, the number of elements as a funnel, right? The more elements you have, the larger the top of the funnel. Or the less patient, or the more patients that you have, the funnel is much larger. The more elements you may add into a small population, your funnel starts to get smaller, because there's only a certain number of people that may meet that criteria that you have listed. So you may list something like, male, 36 years old, from, you may not use a geographic area smaller than state. You may say West Virginia, and this is all totally an example. This is not PHI. I'm making this up on the fly. Veteran, lost a leg in combat. Okay, right now we've already narrowed down the potential to identify who that person is, an enormous amount. So every other piece of information that we add onto there, we could say married, has 4 children, was in a car accident when he was young. Doesn't mean everybody in the state or anybody outside of the state can identify that person, but people who grew up with that person could probably read that and figure out who that is. So that would be something where you would use something more of, but that would be considered an expert determination method, to look at the data, look at it as a whole in combination with one another. And an expert would have to make the determination that, okay, well, the odds of being able to identify this patient or these patients are very low, so we're going to consider this to be de-identified. Or it could be the odds of identifying this patient. And again, you have to think of, it doesn't mean the odds of identifying the patient, maybe a West Virginia patient in California. That's not the way to think about it. Think about all the way to the level of people that might have grown up with this patient. So you think of that. Could they identify this person based upon what I gave them? So that's why it's kind of a gray area a lot of times. So it's not always the best method to just look at the 18 identifiers and base your entire decision off of, well, I don't have these identifiers, I'm cool, it's let's send it on, it's the identified information. And like I said, Cassandra is going to kind of get into this a little bit more about what actually makes it become protected healthcare information. Where does it have to come from to become healthcare information? So yeah, if anybody has any gray area questions, please feel free to ask, or ask at the end of the presentation. Does that mean
That's you, Michelle.
A covered entity, so speaking to what Wes was referring to, is either a healthcare provider, or it can be an insurance company, any kind of government program that pays for healthcare. And then there are healthcare data clearinghouses through, for instance, the state health departments. There are disease registries throughout the United States and the world, where people can gather information on illnesses and such and have registered. So any of those entities would be covered by the HIPAA governance. HIPAA applies when you are, one, accessing medical records, or if you're if you're recording PHI. And there are kind of two areas when you're thinking about HIPAA: a researcher versus a clinician. It's like the same person wearing 2 different hats. For example, a clinician can access the medical record for treatment purposes, and they have access to that clinical data as part of their employment at an institution. Or, however, that clinician is also a lot of times a researcher. But having access to that patient's medical record as a clinician does not automatically mean that they're able to use that information as a researcher. they would need to get special privileges to use that data that they have in their practice as part of a research study. It does require a review and approval depending on what data they're using, and even if they do have access to the data in their day-to-day work with the patient. So when PHI is used in research, the participant must either give permission for use of the information, or if the risk is low, the researcher may be able to obtain a waiver for the use of that information. So what is the difference between HIPAA authorization and a HIPAA waiver? An authorization is preferred. That is where the person signs a permission either in an informed consent form or maybe a HIPAA authorization that allows what information will be used, how long it will be used, and what it would be used for. But a waiver is generally issued when there's no more than a minimal risk to the patient's privacy, and they have an adequate plan to protect the data. For instance, they're going to put it in a secure drive, or they're putting in a locked cabinet in a private office where only certain people have access to that. Written assurance that the PHI will not be reused or disclosed, and that research is not possible without having that waiver. And it also is not possible to do the research without having access to the PHI. So for instance, say you're trying to identify patients where you may want to reach out to them to see if they would be interested in a study. You may be able to get a waiver of the authorization for HIPAA to do that recruitment if the risk is seen as low and you're taking the proper safeguards to ensure their data is kept safe and destroyed properly after you're done using it. Research activities that involve PHI should be conducted whenever practical with patient authorization. So that is the preferred method. If researchers have the opportunity to interact with the participants, researchers are expected to obtain a consent and a HIPAA authorization, which I'm sure many of you know can be often combined into one document.
All right. Thank you. Sorry. Thank you so much, Wes and Michelle. So now we'll jump into more about HIPAA, but also some IRB perspective. So like Michelle said, the big takeaway is that waivers are allowable and certainly are common at WVU, but that is when you're not able to get authorization. The HIPAA regulations lay out a specific criteria, a set of criteria that must be satisfied in order for the privacy board, which at WVU, the WVU IRB serves as the HIPAA privacy board, to grant the waiver of authorization. From an IRB lens and therefore from a privacy board lens, we also view this from the principle of respect for persons, thinking about Belmont principles. So potential participants, right, should be treated as autonomous agents and decision makers. So when possible, they should be able to authorize, right, a HIPAA authorization, authorize the usage of their data. I'm sure many of you on the call are seasoned researchers and know this, but I think it always bears reminding that really participants and their data, because I know sometimes that can get hard to tease out and really think of data in terms of participants, but they're not there, you know, for the researcher's convenience, but are really autonomous agents and should be treated as such. But even knowing that, we'll talk about the HIPAA waiver and what those criteria are. So first and foremost, we want to go to the next slide. The use or disclosure of protected health information involves no more than minimal risk to the privacy of individuals. So having a plan in place about how you're going to safeguard the data. Second, and probably the biggest one to meet, is that research could not be practicably conducted without the waiver. So that doesn't mean that it's inconvenient or too burdensome. It really means impractical, as in impossible to do or carry out. So if there is no mechanism to obtain the authorization, then it becomes impracticable and a waiver can be granted. And then third, you need the PHI to do the research, right? There's no other way to conduct the research without the use of the PHI. So when is a waiver appropriate? So you can see here, and we've touched on it earlier in the presentation, but maybe you need to identify potential participants. So looking through the medical record, or even assessing whether there's a sufficient patient population to do the research. In that case, it might be for recruitment, sort of assessing, but that project may have both a waiver, right, to investigate and see what's there, what the potential participant population looks like, but then later also have a HIPAA authorization for participants that do agree to join the research. Of course, waivers are very common with secondary data analysis or research that's on a large set of medical records. Like we mentioned earlier, if the researchers regularly interact with the set of participants for the study, then we would expect, even if it's only secondary data, for the researcher to obtain assigned HIPAA authorization as well as informed consent. So we lean on the study team through the HIPAA waiver request and the IRB submission to demonstrate that those three criteria for obtaining a HIPAA waiver can be met. And again, you know, Wes sort of touched on this, talking about even if it's not PHI, as you get smaller with the data sets, that same logic happens on this side too. So if you're assessing 5 patients, maybe it's feasible to get assigned authorization for each individual since it's a small data set. So that goes into the evaluation. And then just to go through some examples of our maybe most common scenarios that we see and how HIPAA interplays with the IRB submission. So again, if you're doing secondary data analysis, so something like a retrospective chart review, there's no other research activities, that is the sole focus of the research, then likely you're going to request a HIPAA waiver of authorization because it's probably a large data set. Maybe it's your patients, but it's other physicians' patients as well, and you're pulling information in a large data set from the medical record. So in that case, more often than not, we see a waiver, a HIPAA waiver. A second example, so if you're doing a clinical trial where again, maybe you're looking at eligibility before actually moving forward with the study or using that as a recruitment tool, our suggestion and what we most commonly see would be a HIPAA waiver for that eligibility assessment that you're doing prior to engaging with the participants, and then the use of assigned HIPAA authorization. Like Michelle said, that's typically a combined document with the informed consent, calling it informed consent and authorization. So in that scenario, you'd actually have both a HIPAA waiver and an authorization. Other examples, so if you're doing a prospective study, all activities are prospective, you're interacting with the participant, there's no, pre-review or access to the medical record prior to enrollment, that HIPAA authorization through the combined consent and authorization document is going to be most common in that area. I think where things get maybe tricky, even though the risk sometimes is the lowest, are projects that include or a study that includes like an interview or a survey as well as a chart review. And as frustrating as the answer is, that those studies really come down to it depends. So you may qualify for a HIPAA waiver, or it may require a HIPAA authorization. It really just depends on the details of the project, the scope, the number of subjects, how you're interacting with the subjects. Is it in person? Is it through online surveys? And so all of that sort of goes into the assessment. So I would say if you have questions about that, to reach out to our office or to Wes, to Michelle, anybody, to sort of see what may be the best strategy to use. And then some practical information, which will only be applicable to those at WVU. So to request a HIPAA waiver, it's linked on our website and on our forms page. I'm sure many of you are very familiar with it through a build form, which is OHARP 21, the HIPAA waiver of authorization request. That is submitted and reviewed and approved prior to the submission of the IRB submission. However, we do ask that you have sort of a minimum footprint within WVU-KC in that you've created an IRB submission with sufficient information so that the HIPAA reviewer knows what's going on and can assess whether that waiver criteria is met. That can really speed up and sort of mitigate some back and forths and questions with the waiver request. It's not a perfect process, but when you complete the data protection and determination form, it will indicate based on your questions or your answers to those questions whether a HIPAA waiver is or is not required. Ultimately, the IRB makes the final assessment. So even if you get a certificate that says a HIPAA waiver isn't required, again, it's not a perfect system, and there might be details that weren't captured in data protection that come to light through the IRB review process that necessitate the waiver to be completed. And then the big thing I will say just from our side, as we go through the IRB review, we really want to emphasize that we understand and we're moving to a new system, and we'll see if some of this is mitigated there. But currently, we do understand that we are asking researchers to put in similar or the same information in various places, whether usually through the HIPAA waiver request, the data protection form, and then the IRB submission. Maybe you have a protocol document that you're attaching to add to that source. We would just really encourage you to make sure that data is consistent. The information you provide is consistent throughout all documents in your IRB application. So a lot of the revisions that we see from the IRB's perspective are because the data protection form says these 10 variables, the HIPAA waiver request was approved for 5 of those variables, and then the IRB submission has, a different list of variables. We understand that often there are study teams and maybe different individuals are working on different aspects of that IRB submission, providing regulatory support. But that would just be my biggest recommendation, sort of tips and tricks would be to ensure that consistency throughout to sort of speed up the IRB review process. And then just make sure, after we've discussed it, but to make sure that we're all on the same page. We talked about, and I know we have guests from other institutions, and it's a pretty common practice, but to just know that while we do have a combined document of informed consent and authorization, there certainly is, and we see it with some of our cancer studies or others, where a standalone authorization makes sense. But those are two distinct things, and they serve two distinct purposes, even when they're in one document. So a HIPAA authorization, like this says, is the legal authorization for individuals. They're saying, yes, you can use my protected health information. I give you access for this research study. And that is just a subset in that larger informed consent document, whereas informed consent really is the document and the process where participants, prospectively and voluntarily agree to participate in a study. There are required and additional elements talking about objectives, procedures, basically what will happen, when will it happen, what do I have to do, and what information do I need to know that may affect my decision about whether I want to participate or not. So if you do have a study that uses a combined document, just know it's sort of for the ease of the participant, right? They're only being asked to sign one document that regulatory wise, they're two very distinct processes. You may also have a study that has an informed consent document and then a separate standalone HIPAA authorization. That's totally fine. There's nothing that prohibits it. It really just comes down to study team preference or sometimes sponsor preference about whether they prefer to have the standalone HIPAA authorization or not. And that's really the big takeaway from the IRB perspective. I think the big emphasis is, if you haven't caught on, is that the preference is to get that signature and the HIPAA authorization. But certainly HIPAA waivers are common and are vital to much of the research that happens under our auspices, at least. Wes, Michelle, anything to add?
I just had one thing I was actually thinking, and it wasn't from your presentation or Michelle's or mine, but it made me think of something we probably should have touched on a little bit more. Was when we talk about HIPAA waivers, and I think you and Cassandra, myself, Michelle, you've seen this a lot in the past, but I think it's become much better. But I think something that people, researchers, get confused about a waiver is, if they're doing a study and they want to identify potential patients to approach, maybe coming into clinic, we think this patient, matches, they're coming into clinic tomorrow. If they would like to participate, we're going to consent them. The actual regulation says if you are even going to view patient health information, you need at least a waiver. So even if you're going to look in your own records as a physician, your patient records, for example, or you're going to have a research coordinator look into your schedule for tomorrow to identify potential patients to approach to see if they'd like to participate, you still need a HIPAA waiver to actually do that, to just look in the chart. Then you can approach the patient, the next day, the next week, whatever, ask if they'd like to participate in the study, and then you would get an informed consent or some sort of consent to participate in the study. So, and I've heard, it's not just WVU, I've heard, a lot of confusion about this at different sites, different, universities that do healthcare research, is that, sort of, and it goes back to, I forget who had the slide on the two hats. It was Michelle with the two hats. So that's exactly right. Clinicians do not own the patient records. We hear that a lot. These are my patients. I can look at them. You cannot, actually. The healthcare system owns that data. You would need that HIPAA waiver to even look, again, just look in the record to identify. Even if you're not putting anything in, a spreadsheet, you're not taking anything out, to view it only, you still need that waiver. So I just kind of was thinking about that I sort of missed that. Didn't even think to put that in the presentation, because it's something that I know for sure Cassandra and myself have dealt with quite a few times. But it seems to be a little sort of area of confusion. And again, not just WVU, but just in general about HIPAA and waivers and things like that.
Any questions? I haven't seen any in the chat. I'm going to steal back the mouse from here. Unless, did you want to go through the chat? No? Okay. All right. I guess as a facilitator, I can do that now. I've actually been in the chat, as some of you know, because you've seen me respond to people. I didn't see anything come through chat, but if I've missed something, you have been muted upon entry, so feel free to unmute yourself. Just a reminder, I did drop the CE form in the chat. So if you would like continuing education credits, please download, return that to me by next Friday. I'll give you a whole week to fill out the form, and then just return it to Debbie. Most of you should have my email address. If you don't, I'm in the directory. If you're at WVU, for everybody else at iScore, you guys all have my email. So, any questions for our wonderful panelists?
I
Hey
will just
Debbie, this is
include,
Amy.
oh, sorry, I was just going to
Sorry.
put this guidance document. Go ahead, Amy.
So I have a question just based off of something that happened to me personally recently. So I was in my chart, I had a message from someone doing a study just about a certain medication that I was taking. So that would be covered under the waiver, right? If you want to look at a group of people taking whatever kind of medication, or a group of people that all had maybe myocardial infarction, that would cover everyone in the data set in the EHR that they're looking through.
If that's how they submitted the waiver.
Yeah.
Okay.
It should. So if they used, so there's kind of different ways, Amy, that, for recruitment that can happen. So there could be a message that gets sent out to the entire system, just randomly. It'll be a message that goes out to anybody that's in my chart. Nobody's actually looked at your data in that case. Nobody's even gone through, because it's a study that's sort of open to everybody. There's not a specific maybe disease. It's more of a, like, would you participate to, and I'm just making this up, to like do a study on vision, where you just do a vision chart exam or something. Like, pretty much everybody would be eligible to do that. But to your point, if it was like you said, and it may be an example, but like, you have to have had a myocardial infarction. So somebody would have had to have identified patients that met that criteria. And sometimes it could be, my team here at the WVCTSI who will determine, we'll run a SQL code, a query, and identify patients within a, whatever time frame is specified, who have had, or, within whatever time, a myocardial infarction. We will pass that information to the MyChart folks. So the MyChart people don't even ever look at anything. They just get an approved MyChart message that's gone through the IRB. It's been approved. And we will provide the patient list or the patient emails, and they will just kind of, in bulk, just send that out to those patients specifically. But most of the time, if it's for an actual research study and not like a quality improvement initiative, which we didn't touch on at all here, that's different. But if it's for research, most of the time, probably there should be some sort of a waiver, or at least, an informed consent. And obviously, if you're just getting a MyChart message that you've never talked to anybody about in the past, and you've obviously not consented, but there's probably a waiver.
Okay. I just was curious, because within that was a survey and asked if I wanted to take a survey. So I figured there was a waiver that was associated with it, because I obviously had to be identified.
Yeah.
Thanks.
Yeah. That's a good question, though.
Any final comments for our staff? All right, just a reminder, for you to receive the slides and the sign-in sheet, I have a few people that are on their iPhones. I also have somebody that does not have their full name in the Zoom, so I can't tell who you are. Only those that I'm able to capture your name and email will I be able to send out the slides to you and your sign-in sheet. For those requesting CEs, I did drop that form in the chat. If you couldn't download it, feel free to email me and I'll get that over to you. Once again, please return those forms by May 2nd so I can get them over to our CE office. All right, well, thank you so much to Cassandra Lambert, and I just included you in our staff. Maybe, don't tell your supervisor. I feel like
think my supervisor's on here, but I'll be an honorary member.
You can't have her, okay?
I just know I love that you guys use our platform to do presentations as well.
We appreciate it.
Yeah, absolutely. Thank you to Michelle and Wes as well for presenting today. Sorry, I do see a couple more chats. I just want to make sure we don't have questions. I don't see any questions. Okay. Well, thank you, everyone. Have a great afternoon.